Hello everyone, my name is Rachel Moses and you are listening to the HP Leader podcast. And this podcast is a series of podcasts entitled COVID-19 Lessons Learnt. With this particular podcast looking at the role of psychology and clinical psychologists. So I want to first start by allowing the panel to introduce themselves. So name, role, where you're from. Elaine, if I can start with you, please.
Hi Rachel, I'm Elaine Johnston. I'm a clinical psychologist based at Chelsea and Westminster Hospital Intensive Care Unit in London. That's a general ICU in northwest London.
Thank you, Elaine. Agnes, coming down to you. Oh, Agnes, you're just on mute.
Hello, I'm Agnes Cottage. I'm lead for clinical health psychology at St Mary's Hospital, which is part of the Imperial Hospitals.
Thank you, Agnes. Julie.
Hi, my name's Julie Highfield. I'm a clinical psychologist in Cardiff in adult and paediatric critical care. I'm also just recently joined as a national wellbeing lead for the Intensive Care Society.
Thanks, Julie. Great to have you. And Debbie.
Hi, I'm Debbie Ford. I'm a clinical psychologist working at a Cardio-Thoracic ICU at the Royal Brompton and Harefield Hospital in London.
Thanks everyone, and thanks so much for joining us. So you'll know if you've listened to any of the other podcasts that we've specifically been talking about professional roles, not just within COVID-19, but across really the whole respiratory pathway. So COVID-19 has been a devastating respiratory virus, and for many people that suffer with COVID-19 require admission into the intensive care unit. So I want to first start off by asking the role of the clinical psychologist in the intensive care unit. For some of you listening, you might not even know that that role exists. So I want to come to Debbie first and just say, what is your role? Think pre-COVID time, why is a clinical psychologist so important as part of the MDT-ICU team?
I think hopefully the panel would agree that we're pretty essential for the intensive care unit because we take a biopsychosocial approach. We think about the body, the mind, and also the context of an individual in critical care. One of the most challenging places that people can end up is an intensive care unit with really complex medical needs, a really fast-paced team around them. Some of it's planned, some of it's unplanned emergencies. So having a really well-trained professional within the system that focuses on the mental health, adjustment, psychological well-being, alongside that physical presentation is absolutely essential for the recovery of those patients. Also supporting the team and the other MDT members to kind of think holistically about our patients.
Thank you, Debbie. And Elaine, I'll come to you. So what does a typical day look like for a clinical psychologist? Do you want to think pre-COVID times?
That's an interesting question. It's quite hard to remember pre-COVID at the moment. I think prior to the pandemic, in my service, I'm very fortunate. I have a full-time assistant psychologist. I'm actually part-time in the unit, and between us, a big part of our role is to actually come and just introduce ourselves and meet all of the patients who come into intensive care, just so that they know that we're part of the general team, and that psychological well-being, as Debbie has said, is just as important as people's physical well-being. And we start very early with identifying any psychological issues that people might be having and making sure that we can offer support quite early. So part of our role is around informally meeting patients and relatives and just being there on the unit as a support for staff as well. So they may come and talk to us if they've got a concern, for example, about a patient that they feel is very distressed, or that they'd like some help managing the delusions and hallucinations that they might be having related to delirium. We would also do a formal kind of screening and assessment of people while they're in ICU that would help identify those people who may have longer term problems, and we would follow them up once they're discharged from ICU if they wanted that support while they're still in the hospital. At the moment, our hospital doesn't have a follow-up clinic as such. Some other hospitals do, but our psychology service is still quite new. So we were actually still just building and growing the service prior to COVID, and also just about to move into a brand new unit, which has been especially designed with psychologists involved in the design and planning to try and make sure that the environment is sensitive to needs of patients around things like sleep and orientation and having views and activities and things, and all the things that are very important to improve patient experience. So we have a really interesting and varied role, and I think the sort of the main impact of COVID was on our sort of ability to just be there on the unit doing our job as usual.
Fabulous, thank you. And Julie, I'm going to bring you in at this point for your kind of strategic and national insight as to the overarching role of the psychologist as well, with embedded within the team, because you're new into this ICS role, but it's such an important role. So do you want to give us a little bit of flavour around that?
Yeah, sure. So, I mean, part of my role is really about promoting ICU as a more psychologically informed service, really. And a big part of that is trying to encourage units to develop psychological services. So we've done a big benchmarking, and only about 20% of the units in the UK have a service, but that's great compared to how it was 6 years ago when I first started. So we're supporting local units to develop their services, but we're also thinking about making ICU a better place to work, really. So improving the sort of psychologically informed environment, if you like. So the role is very much focused on staff wellbeing, but I think, that's just as important for our patients and our relatives when they return as well. So I've been working on over the coming months about kind of educating intensive cares, about developing a national programme of peer support, so that actually we can give much more permission to talk about wellbeing in critical care, and also looking at the leadership of critical care units, because leadership is so kind of linked to the outcomes and the sort of the culture of the unit. So my role is very much about that kind of longer term, let's make the intensive care the best kind of environment for us to work in, so that we can provide the best possible care for our patients.
I think that's so important, isn't it, in terms of, environmental factors as well as organisational factors, then the human factors that exist. And, we talked a lot in some of the other podcasts about humanisation of the ICU, and that's a concept so many people haven't heard of, so many intensivists, critical care nurses, therapists. So, yeah, I think, if COVID has taught us anything, it's around the role of well-being, mental health and psychological therapies ingrained within that critical care pathway. So from the highly acute area of intensive care all the way through to discharge, follow-up, and then potentially in the end of life, advanced care planning phase as well, which we can talk about a bit later. So hopefully we'll give a little bit of feel around the importance of psychological therapies and clinical psychologists across the COVID pathway. So Agnes, I want to come to you now to start talking specifically around COVID. Like, if we think back to the beginning of March, London was hit hard in particular, as were other cities. I think obviously we had the first influx of COVID patients, and we went from the planning stage to very quickly, within less than a week, of then being fully operational in COVID times. Do you want to tell us a little bit how that impacted on your team and how you adapted?
So I am not an ICU therapist as such, clinical psychologist as such, and so maybe my experiences are very different from yours. for me and for my team, it was an introduction to ICU. On the one hand, with the COVID patients, and on the other hand, as you're saying, about staff well-being. And so we've had a kind of bit of eye-opener on both those directions. And so maybe what I have to say is that we're a bridge between you as very experienced people on ICU and people who don't have any experience on ICU. So as a clinical health psychology department, I think, you know, we share very much that view that it's the person first, isn't it? It's the person rather than whatever they happen to have wrong with them. And so we went into it with a deep breath, thinking, well, we don't know anything about COVID because, you know, who did at that time? But we do know something about how to approach health psychology, which is we're interested in the patient and what the patient's concerns are, and we're interested in the staff and what their concerns are. So what we found ourselves doing, and if we're just concentrating on ICU, because that's the main thing, on the one hand, recognizing how very interesting those particular MDTs are, that taking part in an MDT where there seems to be tremendous attention, tremendous time given to every individual patient. And we've experienced in other MDTs, you know, that sometimes one rushes past the, you know, the psychological, psychosocial issues. And this didn't seem to be the case at all, that there was so much openness to joint thinking about the nature of anxiety and so on. And for example, one of the people who had a speaking tube in and so couldn't really indicate what his concerns were, and noticing that every time that he got up and they tried to mobilize him, the alarm went off because there was oxygen, as it were, leaking through, and so he was alerting every time to the alarm going off, and that made him just want to withdraw and sit down. So being able to unpick something as simple as that with the staff, and being able to turn the alarm off, and being able to just explain a little bit more to the patient. I mean, I think that to us is entirely obvious, isn't it? It's just kind of bread and butter stuff, but realizing that sort of thing can make an enormous input, and also the extent to which the staff panic if a patient says, for example, they're feeling depressed or if they're feeling suicidal, and being able to kind of move in with that. So that was one thing. And then we were lucky enough, kind of fortuitously, and it was not particularly to do with COVID, but getting some funding to put some themed input into staff in the ICU. And so we're just setting that up with them and thinking of it not as kind of reflective practice as such, and not as well-being quite, but as skills training. And that's been very interesting, about having quite senior input from there and thinking, how do we make sure that it's part of CPD, which is, you know, what certain staff really want, and what kind of themes are there that are really the ones that they want to address. And they will be very familiar to you in terms of death and when things go wrong, and interacting, you know, how you feel when you're interacting with families and so on. Yeah, so I'll stop there.
No, that's really great. And I'm just going to pick up on a couple of points there, and maybe bring Debbie in at this point. So with particular reference to the team. So in COVID times, our intensive care units had to massively increase capacity during surge, and we couldn't magic up IT nurses. So our staffing models changed from 1-to-1 to 1-to-2 to 1-to-3 to 1-to-4, and even at some hospitals, it's sometimes 1-to-6 critical care nurses per patient. So critical care nurses, you know, with the best skills and intention in the world, you cannot provide full care, supportive care for that patient in that model of work. And so this is really where the MDT had a huge role, and this is where therapy had a good role. And particularly for those psychologists that were either redeployed to critical care or embedded psychologists within an ITU team. So do you want to tell us a little bit about how you adapted in that situation, and really some of the benefits that you'll be good to showcase?
It's really tricky actually, because our unit changed, like you said, so quickly overnight. And actually, because we're known by the staff, they became quite protective over us going in, which was very interesting dynamic to witness. All of a sudden, people saying, "Don't come in this red zone. We don't want you anywhere near it." You can see these patients when they are not sedated anymore. The unit became quiet, became silent. The patients were sedated. There were many of them. So our nurses were struggling with, like you say, not being able to do what they normally did on a one-to-one and having to adjust to their quality standard. These are professionals who are used to giving the best possible service to every single patient that they see, and it didn't sit well with them. So I think actually the role of the psychologist shifted slightly from that patient bedside role, because we didn't have a role when they were sedated in the same way. There were no relatives in the unit. We became part of a family support and liaison service where we could provide those kind of that contact with families and relatives that needed that emotional support, who couldn't touch their loved ones, who couldn't be by their bedside holding their hands. So we kind of took that different role, but for the staff, we were helping them adjust to doing their role in a different way, bringing new members of the team in that they weren't really sure if they could trust. So there was a lot of kind of culture, organisational system shifting happening very, very rapidly. So I feel the role of a psychologist for our service became more containment than direct clinical intervention with our patient until they became in that rehab state. The physiotherapists, I have to say, my goodness, they were Trojans. They were on that unit all the time, getting those patients moving, mobilising, whether they were sedated or not. Obviously, lots of patients were being proned, so they had a really hands-on role. But I think the rest of the team kind of were present for very different reasons. I don't know what, other psychologists on the panel would say.
Does anyone want to come in there? Julie or Elaine? Julie, come to you.
Yeah, just to agree, really. I think one of the phrases I had in my head was kicking the psychological can down the road in terms of patient care, because one of the interesting positives of the pandemic, because of shutting down lots of other services, we didn't have as many delayed transfers of cares of patients. So patients moved really quickly the moment they were ready to from the ICU. But what I noticed is they were then all clustered on the same post-COVID ward. So actually we as ICU psychologists ended up working more on the ward with the problems of delirium in the same way that we would have done previously when someone was being desedated on the ICU in sort of previous months. So I think that really shifted things for us, just to say as a sort of an echo and agreement with what Debbie's saying there.
Thank you, Julie. Elaine, coming down to you.
Yeah, I mean, I would also agree with them, particularly what Debbie said about the shift from patients more to relatives, particularly during those early weeks when a lot of our patients were ventilated and sedated, and the nurses were extremely busy, particularly. Our hospital had, along with some doctors and specialists from other departments, had come to support ICU by offering to call relatives with medical updates, just because the ICU team were not able to take their calls while they were in the unit, which I know was really difficult for some of my colleagues, the kind of change in their role. And I think one of the things that the psychology team had done at that time was to try and work with the family relations team to try and make sure that relatives were able to send in photographs and messages and you know, things that were important to the patient. Like we had one Muslim patient who the relative really wanted them to have a sort of machine that played the Quran for them, because that would have been very important and soothing for them. Eventually we were able to set up some video calls. I think that took a few weeks, and the psychology team were quite closely involved with preparing patients for that, because a lot of people hadn't seen an ICU before. The patients had been unwell for quite a long time, so some of them were quite deconditioned, had lost weight. So we were working very closely with the bedside nurses and with the doctors to try and talk to them, to explain about what they would see, and to make sure that they were prepared for that, but also just to support them emotionally. So a lot of our time was from the psychology team was actually contacting relatives early on, and relatives were very, very distressed by not being able to come into the unit, and staff were very distressed, I think, by feeling quite dehumanized in their role, because they are used to delivering compassionate care, where talking to relatives, particularly bedside nurses, having them, you know, being there 12 hours a day, but being used to having relatives in the unit without restricted visiting hours was very different. So there was a lot of, I would say, quite behind the scenes work that we were doing. I think Debbie had also mentioned about containment, and I think the sort of communication and, you know, facilitating communication and containment was quite a big part. Our unit had expanded quite quickly, as others had done, so we had more MDTs than usual, and the level of discussion was as deep and intense as it usually is. So our meetings took a very long time. We were very fortunate. We have a really lovely palliative care consultant comes to all of our MDT meetings. So some of those decisions that were quite difficult for the team, we had some support around, and particularly thinking around the family and the patients in those. So I think there was a real shift in how we worked, at least for a while, until some of the patients started waking up, and we could then facilitate some more contact with them. And interestingly, we had as a psychology team, we had kind of felt you know, like we wanted to go into the unit, because we felt like we kind of weren't quite alongside the team if we weren't. But actually, for some of the patients, they preferred seeing us without all our masks and PPE by video call. So it was quite nice for them to, you know, maybe have a nurse or physio or whoever was working with them at that time to help facilitate the calls. So there was quite a few changes in the way that we worked, and you know, all being done quite reflexively and quite responsively to need at the time.
So thank you, that's so insightful, Elaine, and that's brought us on nicely to start talking about some of the differences or challenges. So we imagine, you know, the intensive care unit pre-COVID, it's an incredibly hostile place anyway. You know, machines, the smells, the sounds, the cleanliness, the sterile nature, and then you add in COVID, which has seen a level of enhanced PPE, especially with different respirator masks, gowns, and the lack of communication, you know, so that does add complexities in, doesn't it? And it adds differences in. So we have a patient who has probably become increasingly unwell, because that's what happened in COVID. You know, they had symptoms. Some people, they escalated quickly over a couple of days. For some people, it was more like a week, 10 days. So these people were admitted into the intensive care unit, probably knowing they had COVID. They probably knew that a lot of people had died, and they may have even been on a respiratory ward beforehand and not seen people survive. So what does that mean from a psychological perspective? On some of the previous podcasts, we talked about this survivor guilt that COVID patients have. Now, I've worked in critical care for a long time, and mainly in major trauma. And normally when people survive, it's quite an elated. There's definitely post-traumatic stress, but they're quite grateful they've survived. So for me, for some of this guilt, I've never, as a physiotherapist by trade, I've never really seen that before, but I know you guys have some experiences with that. So can I bring someone in to talk about that? Debbie, should we start with you? Thanks.
I think it's interesting because I'm coming from a cardio-thoracic intensive care and it's tertiary centre, so we don't have that trauma A&E kind of entry of patients with all different conditions. We've got people who know each other, maybe who are going down the transplant pathway, who may be having a transplant at similar times. One may survive, one not, and there are wards within our units as well that hold the same groups of patients, out of hospital cardiac arrests, those patients who actually do struggle with survivorship. Whether we call it guilt or not, I don't know. Some people it's guilt, some people it's not, but there's challenges with survivorship that are often very difficult to talk about for patients, because the people around them, including the medical teams, nursing teams, will say, wow, we never thought you would survive this. It's incredible. Look at your progress, look at your movement. But that person feels like a shadow of their former self. So there comes the need for a psychologist, somebody to explore, to provide a safe space for those untold stories of survival, those untold stories of rehab, those where they don't want to disappoint a physiotherapist as well, who are incredibly motivating and trying their best to get that person to take their steps so they get out of the hospital. So you become this kind of really nice, safe place for a family, for the patient, to begin to explore the whole kind of story, the whole narrative behind their experience. And that's relevant in COVID too, because you may have, we have talked about this in other podcasts, you may have relatives who've come into the unit and actually one stayed in a district general, one's come to a specialist centre just because of capacity, one's maybe not survived. Then they find out that information, and within families, this is the uniqueness of COVID in my view. Things are happening within families, within communities. It's all known about. We find out that our neighbour passed away from COVID, or their mother did, or there's such a commonality in the story and we're all affected in that way. So I think it's a really complex psychological response that maybe we will begin to see. I don't think we're seeing all of it already. We're still in it, I think, in my view. I think it might take some time to kind of see the outcome psychologically, but this is where the embedded clinical psychologist with that expert knowledge is so key in follow-up, as well as on the units at the same time, because you can try and pick things up. Early intervention is so important. I'm sure my colleagues on the panel would agree.
Absolutely, and you've just picked up a couple of things there I definitely want to pick up on, because there's also that post-discharge challenge, isn't there, with social isolation, and you know, if families have vulnerable people within their, I mean, we'll have social bubbles now, but when we were first discharging these patients who were nothing, we're seeing some people being discharged home, you know, completely living independently, who were, you know, nowhere near their functional ability, you know, with no care support going in. So that the psychological impact of the whole social situation has to be huge, surely. Julie, can I bring you in for comment on that before we move on to the next section?
Yeah, I guess just some other aspects of guilt that I've seen now that we've got through our first sort of 30 or so patients in follow-up clinic. That idea of kind of guilt and the impact on the relatives has always been there, I think, in ICU, but it's sort of shifted slightly, so it isn't that sort of sense of I felt guilty because you were at my bedside, as in previously, because they couldn't be at their bedside, but that I felt guilty because you were at home racking your brains, climbing the walls, not knowing what to do, and I, in to myself as a patient, slept through the worst of this and didn't have to witness this. So you do have a lot of people in our follow-up clinic is video based now, and it makes it much easier in some ways because people bring their families in to follow-up clinic, and you'll have that kind of dialogue with both of them. And then there's an interesting sort of variation on guilt, which is, you know, as a psychologist in the follow-up clinic, people are telling us how anxious and nervous they're feeling about continuing with life, and you know, maybe some of the physical limits and fatigue, and their sense is, but please tell the unit staff thank you, because they invested so much in me. And I think one of the things that I'm very sort of cautious of and aware of in my intensive care society role, which is around staff well-being, is not overplaying the emotional impact of working in an ICU for the public, because I have had some patients who said, I'm devastated to know in caring for me how much it's taken out of you. So there's just something for us to be aware of as a community, and about how we that dynamic between us and patients in terms of their gratitude for surviving, and what do they survive to, and what it takes from us as well.
I mean, it's fascinating. I just don't think ever in critical care medicine we've went into this level, have we, for patients across, and we'll talk about maybe some of the similarities, or if there's any difference at all between COVID and post-ICU survivorship. But I mean, thank you for that. Elaine, can I come down to you?
Yeah, I guess just in relation to points that my colleagues have already made in terms of guilt, I think definitely seen that from patients that we've spoken to, saying actually it was much worse for my relative because I slept through a lot of it, and also expressing concern because of what they'd seen in the media, often before they came into intensive care, that massively increased patients' and relatives' anxiety and staff anxiety. So being very worried about how staff had actually coped and how much they'd invested in looking after them. And I think also being aware, for example, if they were maybe brought in an ambulance to A&E and then went onto a ward, where they were aware of other patients dying, or other patients not going to intensive care because they were all, they weren't able to. So I think there were massive anxieties there, that have greatly increased people's risk of traumatic and anxiety related problems afterwards. And I think the amount of time that people spent on ICU and the gaps that they have in their memory for that, and Debbie mentioned about helping, part of the psychologist's role is about helping to build that narrative. And one of the things that our ICU nurses, for example, usually do brilliantly in our unit is patient diaries. But because of resource limitations, that wasn't as possible, at least not early on. And I think some of the gaps that people have, and also some of the complexity of problems that they're still having when we talk to them, once they're on the wards or once they've gone back home, really highlight the need for very robust specialist follow-up of patients, to be able to come back in and talk to the doctors and nurses who are involved in their care about what actually happened to them, make sure that nothing has been missed, because they were, because they may have had other problems once they've, once they've got back home, that they might still be having difficulties, and particularly with the psychological aspects as well, like just helping people to build those stories. And we're seeing some patients who are really struggling, but I would also like to say we are seeing quite a lot of patients who feel that this has been life-changing in a positive way, that they've made lifestyle changes because of their experience, and also that they feel very, very grateful, not just for staff having looked after them, but grateful that they were able to survive this. And we've seen some patients already getting back to work. They're still managing very high levels of anxiety and uncertainty about what happens if I get sick again, what happens if one of my family gets sick, all those sorts of things, but really very, very mixed experience. And I think the follow-up aspect is very, very important, something that we need to think about, and something that psychologists can definitely contribute to very well.
So that brings us beautifully on to my next section, which is about follow-up. So Julie, I'm going to come to you. So what's the role and importance of clinical psychology when it comes to the follow-up of intensive care patients, and with reference to COVID-19, but actually is COVID-19 any different from our normal post-intensive care discharge patient?
Well, it's incredibly important, I would say that as a psychologist, but it is incredibly important to have us in follow-up clinic, and it is part of NICE CG83 guidelines as well. So we're particularly kind of keen that we meet those guidelines, and part of GPICS as well. What that looks like is slightly different depending on your ICU, but typically you've got two models of follow-up. You've got the kind of carousel model of follow-up, which is very much around kind of see the doctor or nurse and then see the psychologist, and maybe if you're lucky you might see a physio or a dietitian, or you have the kind of all in together, see all of the professionals together. I've actually done both, and there are pluses and minuses to each, and I think the most important thing that we bring as a psychologist is, you know, all of us can do little p psychology. All of us should be interested in what's going on for a human being, how their life is shaping up post ICU. But as psychologists, we're professionals and we're trained to do big P psychology. So we can see the nuances, we can do the screening, we can ask the questions and kind of listen for what's unsaid, and kind of press and question in a particular way that comes from years of experience, that helps people to really make sense of some of the things that they can't even put into words for themselves. I think a lot of the PTSD we see in patients is they cannot actually find a tangible story to make sense of their experience, and that is our specialist and unique kind of talent that we bring to critical care follow-up. In terms of, is COVID any different? I think there's a lot of similarities between the kind of PICS, the post-intensive care syndrome of pre-COVID and COVID, in that a lot of patients can be traumatized by their experience of the ICU. A lot of patients have experienced delirium. A lot of patients are left filling in the gaps of their stories, wondering if they're still vulnerable, experiencing anxiety about getting back to life and kind of getting back to body confidence, if you like, and all the things we've talked about in terms of the impact on their loved ones. I guess the emphasis I've seen that's different for me so far in the small kind of cohort that we've managed to follow up in South Wales is that there seems much more emphasis on fatigue. For me, that's the striking difference that I'm seeing. I'm not actually seeing that much difference cognitively so far, but it's early days, but big difference in fatigue for me.
Thank you. I think that summarised it beautifully. Thank you, Julie. And again, you know, we've said this in previous podcasts. If people still don't understand the role and the importance of the clinical psychologist across critical care pathway, there's so much information out there. And now Julie's enforced, we can signpost you to some of the resources out there. So, Debbie, I want to come to you next, because we can't really have this podcast without talking about staff support and the mental health, wellbeing and psychology of staff, and, you know, the impact of COVID-19. And if we think about COVID, we think about something that's translatable in the future for a pandemic of whatever description, you know, something that's affected staff, our colleagues. We've lost colleagues. You know, where is the role of the clinical psychologist? Maybe as an embedded role, maybe as a referral role within hospitals, within healthcare. You know, what have we learned from this?
You need more of us. You need expert trained, highly qualified mental health staff to look after your staff, to be able to cascade that containment down to patients and other team members. So I think as ICU psychologists, we've known for a long time, you walk in an ICU, you see what staff teams are exposed to straight away. That's the one thing I always say to anybody that comes to our unit: hold on to that feeling of the first day you walked in. You heard those noises, you smelt those smells, you saw those patients, because you very quickly habituate to that as your norm. And now we've got a new normal with PPE. Again, we habituate. We're skilled at doing that. We're adaptive human beings. But you need people within the unit who can break that apart, pull it to pieces, deconstruct and help someone rebuild, whether that be a staff member, whether that be a patient, their relatives. I think there's a role for embedded psychology in staff support, occupational health, HR, but there's also a role for embedded support within the ITU as well, which can provide that day-to-day sense checking, that day-to-day can I just have a quick cup of tea, that informal support, as well as the formal training, teaching, reflective practice. There's a multitude of things that we could be doing better. There are so many things we do well already though, and some teams are absolutely brilliant at taking care of each other, but they need somebody who can sit just to the edge sometimes, who can just provide that kind of observational, we call it a meta perspective, kind of looking down over the system to just support and help that organisation, that team, that department function to the best of its ability. So yeah, that's my answer. Always more of us.
So I'm thinking with my manager head on as well, because there's a double-edged sword here, isn't there, with having a clinical psychologist treating patients and then there being a staff need identified, and we've got to be really careful of that overlap, because being embedded as part of that ICU team, you're a team player, but then there's that trust that comes with the, you know, being the psychologist and the relationship. So Julie, I mean, we've spoke offline about this and about how do we do it right? Definitely a need there, definitely importance, but what's the kind of magic? How can we make this happen and not just steal resources? So we've seen psychologists being deployed into the ITU, and some ITUs had dedicated clinical psychologists for staff, and I think that's how they've done it. They said, right, you're not just looking after patients, you're just looking after staff. Is there a magic?
I think the magic ingredient is boundaries. Actually, I think there's lots of different configurations as we've spoken about. I think there are pluses and minuses to that integrated configuration of staff support versus that referral pathway too. But I think the most important thing is that it's about that the way in which we manage boundaries. And I think there is something that is so valuable about the ICU learning to trust a known face. And I think big, busy units see a lot of death, they see a lot of staff turnover, they really, really do struggle with that trusting relationship. And they need to know that if you're coming into the bed space to see a patient or a relative when they're back in the future, that you're not going to disclose what you know about them from having seen them sort of break into tears in the sluice. You know, that you can kind of wear different hats. And I think most psychologists are good at that. Not all psychologists are good at that, and hopefully they will vote with their feet in terms of going for those kinds of roles. But I think the other key part of it is choice as well. So I know in my day job, I have worked for years doing both, and people have come to me and that's been their choice, but they've also had the choice of occupational health, and they've also had their choice of primary care, mental health, GP surgery as well. So I think it's really, really important that if we're integrated embedded psychologists, we don't say we're it, we're all you're getting. So we need to rise above that and signpost people appropriately and realise when there are conflict of interests and when boundaries have been breached as well.
I think you've just absolutely summarised that perfectly in a very short time. Boundaries, roles and responsibilities, and then multiple options, because one model doesn't fit all. And I think the intensive care units that have that or developing that, I think that's the magic, isn't it? And that's the way forward for sure. So I just want to finish up. I'm conscious of time now, so I just want to come to each and every person with a final question of, you know, what have we learned and how can we be prepared for something similar in the future? So, you know, a second surge or a pandemic in the future. For some of the therapists, it's been around having a constant level of training within our professions, so we don't have to do this mass training, that people being orientated to different areas, to stop working so much in silos. Like for you guys, what is your kind of lesson learned, and how are we going to keep, you know, this preparedness level, you know, or like similar level for the future? Elaine, can I come to you first?
Gosh, that's a tough question to finish with. I think it's been, you know, just thinking about the, you know, in terms of what we've learned. I mean, one of the things that has been amazing as a resource for psychologists working in intensive care has been the Psychologists in Intensive Care network that Julie and Dorothy Wade co-chair, because I think that has just been incredible right from the start. Psychologists across the UK were able to sort of share experiences of what was happening in their units, share resources, share ideas, very informally and very collaboratively. And I think that is an incredible resource. And I would definitely say, well, we need more of that. And hopefully we just need more psychologists who know about intensive care and work in intensive care as well, because I think it is a very different specialty, and I think there are crossovers if you've worked in other physical health areas, there are crossovers if you've worked in PTSD and trauma, but it is also a very specialist language that can take you, you know, a good 6 months to a year to get up to speed with what the team are discussing. So I think making sure that if we're looking at intensive care capacity to respond to surge and future pandemics, that includes psychology. And a lot of the work that people have been talking about making psychology embedded fully within intensive care, that's quite a sort of systemic approach to work that actually needs the psychologist to be there. I really don't think that you can adequately just parachute people in at the last minute and expect that they will get up to speed. I think people did amazing jobs of supporting intensive care psychology teams, and particularly around staff support, but on the clinical side, I think that was much more difficult to train people up to do. And I think just finally, sorry, I won't keep hogging the mic, but I think finally, in terms of, Julie mentioned like the little p of psychology, and that's something like within our team, I feel like my role as a psychologist is not to hold all of the knowledge of psychology, but it's very much about sharing and disseminating that with the team. And intensive care staff are already very psychologically informed. They are highly skilled, they're very compassionate in their approach, and a lot of it is just about increasing their confidence that they know that the approach they're doing is kind of up to date with current evidence based, and being aware of the models and being aware of the literature. So I think some of the ongoing work around training, consultation and improving peer support structures for staff as well, I think are just so important. So I guess there's definitely there's no kind of shortage of what we could get stuck into, but I think it's a resource issue as well, about making sure that we actually have the capacity to do that as effectively as we want to make an impact.
Thank you, Elaine. Now, you guys, I don't know if you've got much more to add, but I'll come to Debbie first and then Julie to finish.
I think when you said that question as well, Rachel, I think I went, wow, that is a tough one to answer, because I had this image of people in the sprinters blocks getting ready to go next time round. And I don't think that we need to do that all the time. I think it's about rotating people, saving energy. It's going to be, if there is a second wave, I wonder how more, what we'll see in the staffing groups, what we'll see for the patient cohorts coming through, relatives as well. people are quite exhausted. So how are we also going to take care of ourselves as psychologists? Because we are not islands. We feel depleted too. We get burnout as well. We get compassion fatigue. There's something about, as Elaine said, that kind of peer support network for us too, leaning on that a bit more, leaning into those people that give you that encouragement, that compassion for yourself, so that you can be the best you can possibly be in work, sharing knowledge. Maybe there's something about publishing some of our experiences and making it a bit more high profile. There's been lots of people like Julie and Dorothy working on those sorts of initiatives, and they make a difference. We start hearing others talking about ICU psychology and hearing others talking about follow-up and how we rehab, and that's been a really lovely development. I hope that continues. The push of resources into rehab feels like the one thing we really need to hold on to, in addition to Elaine's points.
Thank you. And Julie?
So just to take a slightly different kind of view on this, I think one of the really interesting paradoxes of the pandemic has been that it has really connected us across so many boundaries. You know, with Zoom and webinars, we're connecting over different countries, not just around the UK. But I also noticed absolutely with PPE how quickly the social fabric on the ICU itself disintegrated. And I think if there is a lesson to be learned or some repair work to do is finding a way that all of these virtual support networks we have versus day-to-day working in PPE and you can't even recognize each other, about finding some way in the middle to repair the social fabric of our ICU, and whether there is a way in which we use kind of technology and we as psychologists both take advantage of that for our own peer support and our own connections, but also how we enable that within our teams.
Thank you. So I completely agree with all of your points, and I just want to say a massive thank you for joining me on this podcast. It's been really great to hear your insights and experience, and yes, definitely get some stuff published. So thanks very much.